behalf of everybody here, all the staff who are here, and on behalf of the two CCGs, Greater Huddersfield CCG and Calderdale CCG, and the Acute Trust, Calderdale and Huddersfield NHS Foundation Trust, thank you so much for coming along. Thank you so much for coming along and being part of the consultation, being part of the conversation, and being part of the debate. It's really important, and we're thrilled to see you all here. It's fantastic. Okay, for those of you who have already listened to this, my sincere apologies, but I just have to tell you this again. Okay, tonight we're going to have a Q&A, and we're going to have the opportunity for you to give your opinion, view, or whatever it may be. There's this little form here. Please write your question, view, or opinion on there, and then when we do the thing later and I come around with a microphone, you can just read it out. It makes it nice and simple. You don't have to do that, but please do. Okay. So, so welcome to this public consultation on the proposed future arrangements for hospital and community health services across Calderdale and Huddersfield. Okay, so I'm going to quickly run through now the structure for tonight's event. So, first of all, I'm the chair. My name is Stephen Williams. Okay, and I'm going to give a short welcome and give you some more information in a moment. Then after that, I'm going to introduce the panel and go across the panel. Then there'll be a short presentation. It'll be about 10 to 15 minutes. We know there's a really broad spectrum of knowledge and understanding about the proposals in this room. There's some people who've gone through every document on the website, and there's other people who've got their information other ways, perhaps to look at the newspaper or whatever. That's fantastic. What we want to do is just give you that presentation which just goes through everything, the reasons for change, what the proposals are, the model and everything. And then we'll go straight into the Q&A. So that's in about 15, 20 minutes time, we'll go straight into the Q&A. And that's when those forms that I've been urging you to fill out, that's when you'll see the importance of those. Okay. So just to say that this event is part of a whole series of other events, including drop-in sessions. The last one was on Saturday, and there are two more coming up. One's on Wednesday and one's on Thursday, and there's a little form on your chair, and that actually tells you when all the others are. Tonight is going to be very much about one question to the panel give a response. But if you go to those drop-in sessions, you can sit and have a long conversation. I've just been talking to a gentleman at the front. He said, I can't remember which clinician he was speaking to. He had a long dialogue, a long conversation with him. So that is possible. Okay. So who am I? Well, as I say, I'm Stephen Williams. I'm the independent chair. And I'm from a different organisation to those on the panel. An independent organisation. We've been commissioned by the CCGs and the Trust to provide, and I'll read this out, independent analysis and reporting on the feedback received from the public as part of this consultation. And basically what that's referring to is all the information that you give. So we're recording tonight, we'll be typing that up verbatim, the consultation survey, we will be analysing the results from that, we'll be looking at all of that data as well. That will all go into the report. So nothing will be missed, it will all be included, and then it will all go to the panel, so that when they go through their decision-making process, they've got that report to work from, with all that information. Okay. Next slide. Okay, so some housekeeping things that I just need to go through. I think hopefully you would have found the toilets. They're just out either of these double doors. If you've got any issues, speak to one of the members of staff and then get you there. If you've got your mobile phone and you want to use social media, that's fantastic, that's not a problem at all. But can I please ask you just to put your phone on silent? Because one or two going off, it's perhaps not too much of a problem, but 30 or 40 of them go off, it's a bit of disruption. That'd be great. The emergency exit, we're not expecting a fire alarm tonight. If it goes off, I understand that you stay in your seats. There'll be an announcement over the tannoy, and they'll explain exactly what you need to do. We are, as you've probably gathered, there is filming tonight. There is immediate live filming down into the room below so that they can see exactly what's going on up here, and they can see it and hear it and view it. So hello to the overspill room downstairs. And we're really delighted that you've come along as well. I think they can see me, but I can't see them. And also we welcome BBC Look North, ITV, and also this is being live streamed onto the internet. So there's people sat at home who are watching the debate as well, which is absolutely fantastic. Now before before we move further, I just want to talk tonight about how we're going to work together and sort of how the structure of tonight's going to be. I've told you a little bit about that, but I want to talk to you about now the Q&A and how we're going to work that bit. Now, we received 29 questions from 6 different people before the event. And I know that some of those people are here this evening, and I think they thought that if they emailed in that their question would be raised. Now, every question, every point of view that you put forward, as I've said, is going to be answered, is going to be responded to. As many as possible tonight. What we suddenly thought is that we've got 29 questions, which one do we choose? And then it looks like we've picked a nice one or whatever, and we didn't want to do that. So we think there'll be more than enough questions from the room. So we're going to take questions just from the room. Now, all the questions that you put forward on those sheets, we want to gather in at the end, along with those 29 that we've already received. So what we want to do is bring them all in, and then we're going to read through all of them, and we know that we'll be able to bring similar ones together, almost steam them into questions about finance, and so on and so forth. And then we will put published response onto the website. If you don't have internet access, speak to one of the staff and then we can talk to you about how we can overcome that for you and how we can help you there. But essentially, everything will be responded to. All right? I don't want anyone to think that, I'm not going to be able to raise my point if I can't do it tonight in the room. You will be able to. But you might get a response in that different way. All right? So I just want to go through this now. So tonight is the chance to ask that question. When I come up to you in the Q&A, because there's so many people in the room and we want to get through as many people as possible, I'm really sorry, but I'd be really strict. And it's going to be one question per person or one view or whatever. So you get the chance to read it out. We'll go over to the panel, they'll respond, and then I need to move to the next person. And that's not because I don't want you to have a follow-up feedback. It's because we want to get through as many people as possible because we know you've made the effort to come here. So I know that's a bit difficult, but when I'm stood there, you might hear a voice saying, can you get to the question? What's the real point you want to make? Because that's what I'll be looking for. Okay. But don't worry, you won't be harassed or there'll be no pressure, but that's what we're looking for. Okay, so we can get through as many people as possible. And obviously, it's going to be one voice at a time. Those people on the microphone's all going to be recorded. So when I come over with the microphone, you'll be recorded, you'll be the voice that we hear, and that's the voice that the panel will be responding to. All right. Okay, just so that everyone's really clear on that one. And every opinion and view counts. And we know there's some real passion tonight. There's lots of different issues and concerns and viewpoints that people want to raise, and that's fantastic. We're looking forward to hearing what all of those are. But just think about when we're in the heat of the moment and your passion and how you express yourself. I don't think there's going to be issues, but I'm just saying that it's really hot in the room, as well as a lot of people. Okay, so I'm now going to hand over to Dr. Steve Ollerton, who's going to give us his presentation on the proposals. And then we'll come back and do the Q&A. Okay. Introduce the panel first. Oh, my sincere apologies. Yes, the panel. I knew I'd forget something. I knew that would happen. Right, okay, the panel. So, can you all grab this sheet here, this little document here out of your delegate pack? So it says introducing the panel. The first person on the front is me. It tells you the organisation I'm from. So, if you want to ask any questions about that, please do, but can you do it afterwards so we can get on to the main thing? But I'll be more than happy to answer any questions on that. First person here is Dr. Allenbrook. Sir, could you put your hand up? Thank you very much. I'm going to stand out the way so they can see you. So Dr. Allenbrook, lovely. The next person is, Dr. Allenbrook is the Clinical Chair of Calderdale Clinical Commissioning Group. The next person is Dr. Matt Walsh, and he is from Calderdale Clinical Commissioning Group, and he's the Chief Officer. The next person is Dr. Steve Ollerton, and he's the Clinical Leader at Greater Huddersfield Clinical Commissioning Group. Steve's going to give the presentation in a moment. Then it's Carol McKenna. Carol is the Chief Officer at Greater Huddersfield Clinical Commissioning Group. Then Owen Williams. Thank you, Owen. Owen is the Chief Executive Officer at Calderdale and Huddersfield NHS Foundation Trust. So I'm going through these in sequence in your little profile, so it's nice and easy for you to follow. The next person is Dr. David Birkenhead. He's the Medical Director at Calderdale and Huddersfield NHS Foundation Trust. Then we've got Janet Yowd. Janet is the nurse consultant for emergency care at Calderdale Huddersfield NHS Foundation Trust. And finally, Dr. Mark Davis. And Mark is the clinical director for the emergency directorate at Calderdale Huddersfield NHS Foundation Trust. Okay, so that's the panel this evening. Steve, over to you. Thank you.
Okay, I'm hoping you can all hear me, and I haven't decided where I'm going to stand yet, so I'm coming down a bit. Now then, I need to take that thing with me, don't I? Where's it gone? Oh, that's a good start. Where's the clicker? Oh, there it is. Sorry. Right. Thank you for all coming this evening. As I know that's already been said, but we can't say enough. We do want to hear what you've got to say. Yes, I'm Steve Overton, GP at Skelmanthorpe and the chair of the CCG. And so, as I've been called this evening, one of the architects of the proposals. You probably didn't expect to see a picture of a baby as at my first slide. What I wanted to tell you is this is actually Evie. Evie is actually 4 days old. She's a Huddersfield lass. She lives in Brockholes, near Honley, with mum, dad, sister, Poppy, who's nearly 2. Now, she was actually born in Calderdale Royal Hospital on Thursday. And so one of our newest Huddersfield residents. Now you might say, well, what's so special about that? She's back at home now, nothing very special. One thing I did want to say, she's actually my niece. I'm her Uncle Steve. And so I want you to think about that when you hear about what I've got to say and our new design for the NHS in the future. Because I need to design, me and my colleagues need to design an NHS that's not just good for Evie and Poppy, but also my family, who live in Huddersfield, my patients, 9,200 in Skelmanthorpe, but then the whole of Huddersfield and Calderdale. The proposals you're going to hear about this evening are for the whole population. I want to improve the NHS health services for the whole population, and this is what we're going to do. So, I apologise, some of you know this, and anything that you miss is in the consultation document, and I want to go through this quickly because I want to get to the questions. So, what are we trying to do? Secure the future of health services, I've said. This is going to involve significant investment in both towns. Nearly £500 million in both towns. That's lots of jobs, lots of opportunity, and much better at the end of it. We want 2 state-of-the-art hospitals. That's what I'm talking about. We're going to build on care in the community. We're going to make sure our hospital standards are improved. The current standards in our current hospitals, some of them are not to national standards. We fail on a number of areas, and we certainly need to address those as a priority. And we want to make our hospitals a more attractive place for people to work. Okay? So, the challenges we face. I meant to tell them that I wanted them in a different order, but I didn't. Quality, safety and patient experience is the most important for me. This is why we started this whole process. We want better quality. We want a safer hospital. We know that that our current services are not as safe as they could be, but we're going to improve that. We know that staffing is an issue. We know that consultants are leaving. There's hardly a month goes by where I don't hear of another consultant having to leave and having to get a locum in. That's not good. We need to make it a better place to work. We know we've got an ageing population and a changing population that needs more specialist care, and we are determined to provide that for our population. And then finally, and I know it's talked about a lot, there are financial pressures. And I'm not going to hide from those, but they are there. Okay, so what are we consulting on? Everything, basically. Everything to do with hospitals, and then down at the bottom, also the community services. I'm going to go through these individually, so I won't read them out just at the moment. Okay, the thing that everybody gets very concerned about is urgent and emergency care, and rightly so, because that is when you are your most vulnerable, is when you are very sick. Okay, however, the majority of people are not very sick. About 54% of the current people who go to A&E, we think will be dealt with in an urgent care centre. We're planning 2 urgent care centres, 1 in each hospital. These are for non-life-threatening illnesses, as I've said there. These are for broken bones, for things you might see a GP for cuts, bruises, sprains, burns, all that kind of stuff. Head injuries, etc. That can all be dealt with mainly in an urgent care centre. However, some people are very poorly. They need an ambulance. They need to be taken to a specialist emergency hospital where there are specialists 24/7, which we don't have at the moment. When you get there, you want to get your scans quickly, you want to get your diagnosis quickly, you want to get your operation quickly, if that's what you need. And you want all the specialists in the same hospital. You don't want some of them 5 miles up the road, which is what we currently have at the moment. Okay, so I've mentioned the urgent care centres, I've mentioned that, yeah, 24/7, none of that should be a surprise. Have a look in your programme if you want to read more about those. Okay, planned care, this is your operations, this is your hips, your knees, your gynecology operations, your gallbladder. All of those operations that need doing are going to be done in a brand new hospital, 10 operating theatres, 120 beds on the Huddersfield Acre Mills site. This is where the majority of planned care surgery will happen. But as you will well know, increasingly we manage to do stuff as day cases now. This is where you go in and out on the same day. That can be done at both hospitals, so you won't have to travel further than you need to for those. But the majority, as I say, of certainly people who need to stay overnight will be on the Huddersfield Acre Mills site. And don't forget the urgent care centre that's there as well, and the outpatient departments. They will still be on both sides. Okay, paediatrics. Paediatrics is one thing that we really do need to sort out. At the moment, we have surgical paediatrics on the Huddersfield site, and we have the medical paediatrics on the Calderdale site. And the consultants have to try and make their way between the two, depending on where they're needed. We should have a designated paediatric A&E. We don't have that at the moment. Most of the hospitals in the country have paediatric A&E. We don't. Because there's good evidence that you should, that having doctors and nurses who are pretty much dedicated to dealing with children gives them a better outcome when they go into hospital. So that's what we're going to design in our new service, in our new proposals. And obviously behind that there will be the maternity unit, obstetrics, and as I say, there'll be medical and surgical paediatrics all on the same site together rather than them being split. Next one, maternity. This is the one that isn't going to change very much. We do want to increase the community element of maternity, but actually in our proposals, not very much changes from what it currently is at the moment. And as I mentioned with Evie, she was happily born at Calderdale on Thursday evening without any problems. So, apparently parking. We managed to get there all right, but couldn't park. You might want to think about that. Okay. Community services, finally. For those of you who've been following what we did last year, our Care Close to Home, which was basically a revamp of community services, that's only just been running for 6 months, and we're confident that's going to deliver an awful lot more than it does at the moment, because ultimately we want more people dealt with closer to home. They shouldn't have to visit hospital if they don't need to. So as I say, I'm not going to stand here and say that they're all fully functioning and brilliant at the moment, but they're going to get better. And I want, as a GP, I don't like having to send people into hospital. I want to be able to deal with them in the community if I can, and we need to up our game to do that. So, I'm sorry I'm rushing. Here we go. Calderdale and Huddersfield both have an urgent care centre, both have a midwifery-led unit, both have outpatients, day case. Majority of stuff still happening in your local hospital. Okay, more community health services. However, Calderdale, the emergency centre, where we put all the specialists who want to help save your life in one hospital. And that's better than what we've got at the moment. Okay? Travel and transport. I'm sure we're going to hear about the Ellen bypass this evening. It concerns me as well. I bet there's not a person in this room that hasn't travelled along it. However, you're in the ambulance when you get there, and we'll happily. If you get there. Okay, I knew that was
So what are your plans for that then?
I'm nearly finished. I have nearly finished. We did consider doing it the other way around, as this slide shows you. We did consider it the other way around, because I've heard before that, you know, Huddersfield is a bigger town. Taking you into enjoying the presentation. And so yes, we did consider it the other way around, okay? And I don't mind admitting it is financially driven that we have done it this way round with having
But it's not Huddersfield people's fault.
Okay.
Mismanage the financial issue.
Exactly.
You destroy the finance.
Exactly.
I am making it a better health service for the whole population, as I have said.
You
Okay.
don't even use the hospital yourself.
I'll answer that one later.
Yeah.
Okay. My son was in A&E this morning, actually, at Huddersfield. Anyway, there you go.
Go there, there isn't it?
Yeah, he made it, don't worry. Okay, I'm now going to move, so yes, I think we've just discussed this now. This actually shows the criteria applied: quality of care, access, value for money, and bit for the future. And Calderdale actually is a better option. Let's move on to questions. Happy to answer questions, Steve.
Thank you very much. Okay. Steve, thank you very much for your presentation. We're now going to move into the question and answer session. Okay? Fantastic. That's what we want to see. Brilliant. Okay, so let me just run through quickly how this is going to work. My colleague, Linda, is going to distribute 10 cards, numbered 1 to 10. And I'm going to come round and I'm going to go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, one at a time. Linda's not from the area, so she's going to randomly distribute them. She doesn't know anyone, as I don't know anyone either, because I'm not from the area either. It's totally unbiased. We will go round as frequently as we can, all right? But remember, we will collect all these in and they will be responded to. Please remember this, okay? So, can I just address downstairs in the... Is it the Howard room? Because they didn't catch all of my first part of the front of the presentation. So, everybody downstairs, this is for downstairs, so please bear with me, my full apologies. I have to talk. They didn't hear me downstairs. So this is for downstairs, okay. Ladies and gentlemen downstairs, you have this question sheet here. If you have a question, please fill it in, and Dawn is going to distribute 5 numbered 1 to 5 questions downstairs for however many randomly. You'll then be brought upstairs so that you can also participate and ask your question. Okay, I think that's clear for everybody downstairs. Thank you. Right, so let's go up here. As I said, we've asked 1 question from the floor and then we're going to go straight to the panel and get them to answer. We're going to get around as many people as possible. Okay, so who's got card 1, please? Fantastic, madam. When I come over to you, I'll hold the microphone. If you just stand up and say what your name is and where you're from, or if you don't want to, that's fine, but you might like to do that. And I'll hold the microphone, so you don't need to worry about holding that, okay?
So you can take it away.
Certainly not, sir. Right, ladies and gentlemen, I'm really sorry about this. There are 3 cars that are parked in a pet shop, and they need to close the pet shop, so if this is one of your cars, you've got to go and move it. Otherwise, I'm guessing it will be locked in for the night. So the first one is an Audi, registration OV61JFJ. That's OV61JFJ. The second car is a Ford, and the registration plate is KL06LFX. KL06LFX. The third car is a Vauxhall, registration plate YH64JXS. YH64JXS. Okay, I'm guessing it's nobody in the room. Right. Question number 1, please.
My name's Christina George, and I live in Huddersfield, and I'm a Huddersfield resident, and I've lived here for not all my life, but an awful lot of it.
Okay.
So my question to the panel is, The notion of codependency and reliance on other strategies such as care closer to home is undermined by the number of GP and district nurse vacancies in the district and the ageing profile of both these groups. Nationally, and particularly in the north, GP training vacancies remain unfilled, and there is a national problem of recruitment and retention of GPs. What assessments will be put in place to ensure that community-based services are fit for purpose and able to meet demand prior to any changes being made to hospital-based services?
Thank you very much.
Yes? Am I going? Yes? Sorry. Thank you. Great question. We are aware of that. There are GP shortages, and not as acute in Huddersfield as they are in other areas, but I know they may be coming our way. We have just launched our primary care strategy, which was approved at governing body last week, and as part of that work, there is a workforce element to it, and we have now got regular meetings with workforce. What I said right at the outset to all my GPs when we were working on that strategy is we have to design the future that has fewer GPs, because that's what they're going to be. This is where we are. Look, I don't like that as much as you don't like that. But that's the fact of the matter, and the fact is, in the future we will need pharmacists, we will need nurses, we will need nurse practitioners, we need healthcare assistants. Okay. So all I can say is I can only deal with the problem that's in front of me. If we want more GPs, and I know the government have been promising more, great if they can provide them. But I don't see where they're coming from at the moment. We need to make general practice a better place to work, because at the moment, you ask any junior doctors out there, they're not looking at going into general practice. We need to make the job more appealing. That's my job, to try and make general practice more appealing, and I'm going to try and do that.
But that's not the answer to my question. My question is that what assessments will be put in place to make sure, to ensure that community-based services are fit for purpose and able to meet demand prior to any changes being made to hospital-based services. That's the question.
You're absolutely right that before we actually implement any changes that we make following any decision, that we need to make sure the system as a whole could cope with those changes. So I think we need to be clear that we're going through a consultation process at the moment, and the expectation is that when we go through that process, it will be October time before we actually make any decisions as a result of consultation. But then what happens is there is always an agreed plan to do further work to determine the pace of implementation of...
Can you speak up a bit? Speak up a bit!
So,
There's a lot of noise coming from outside.
there is, yeah, sorry. I'll keep talking loudly.
Stand up so we can see you there.
That's fine, okay. Alright, is that okay? Can you hear me any better?
Yeah.
So as I was saying, if and when any decision is taken, we would need to agree a clear implementation plan for anything that we were then intending to do. That would be accompanied by a piece of work that we'd call a full business case, and then that would set out the sort of indicators that you're describing that would give us the confidence to then enact any changes. So it's not a case of taking a decision one day and starting to make changes the next and hoping for the best. That's the process we go through.
So what assessments will be done? Yeah. You're not answering the question. You're not answering the question. If there is insufficient provision within the community, what will you do? If you can't recruit GPs, if you can't fill the district nurse vacancies, if you can't have hundreds and thousands more babies being born in the community, because that was a figure that was in your pre-consultation business case, what will you do? How will you do that? I understand you need a full plan. Everybody needs a full plan. But what will you do if those services aren't in place?
Well, let's be clear. We're not going to make any changes changes if we think making those changes will not be safe. And I know you'll all have a view on that, but we'll need to determine what the measures are that we will look at in order to decide that it's now safe to make any change that we decide needs to happen after a consultation exercise. So I can't sit here tonight and say, well, we're looking for this, this, this and this, but we do have within our contracts for community services, for example, a number of things that we believe will give an indicator that those services are working well. And that's the kind of thing that we'll be looking at before any changes that were decided on would actually happen.
Okay, we need to move on.
We get 20 questions at Calderdale. We can do better than that here, so come on, let's get some more questions.
We need to move on. Ladies and gentlemen, can I... Ladies and gentlemen... Ladies and gentlemen, please. We're trying to get through, and we will get through as many questions as we can. Okay.
Will it stay till the middle of the night? We get all the answers.
Sir, we have 2 hours to run through, and we are going to pack that with as many questions as we can. And we're going to move on to the next question. Question 2. Question 2. Madam.
My name's Jean Booth. I've lived in Huddersfield from being 12 years old. My children were born in Huddersfield. And one question, my understanding is that one, maybe 2 babies have actually died on the Ellen bypass. Yeah. There'll be more traffic if the Huddersfield HRI is closed. What are the plans to deal with this problem? Has that problem even been thought about? No.
Thank you for your question. Can everybody hear me? No. Do I need a microphone? My name's Janet. I'm a nurse consultant in emergency care. And if you cut me in half, it says children's emergency nurse. My involvement in this consultation has primarily come as a response to my frustration of not having dedicated children's emergency services on either site. I know what good emergency care looks like. I've worked in Leeds, I've worked in Nottingham, and I really do believe, and I wouldn't stand here both from my profession and as a resident of Huddersfield myself, if I didn't believe that we could get better emergency care by having a dedicated children's department where I can recruit children's nurses, where I can recruit children's doctors.
But why in Halifax, not Huddersfield?
And I think
question about the traffic.
Yeah. I think the traffic is a very relevant issue. Certainly.
So what is being done about it? That was my question. Have you considered it?
I'm here to respond to clinical questions around why we need a dedicated
It was about children dying on the Ellen bypass. That was the key.
We have considered the traffic, and we are pleased that Calderdale Council are investing in making the Ellen bypass dual carriageway so that people can get through. And as Janet said, we are confident that the new paediatric service will save lives of children, and that's why
What about everybody else, not just children? That was just an example. What about everybody else?
we are confident that more lives will be saved with these proposals.
Still not answered it properly.
Okay, so your question was about babies dying on the bypass.
No. Your question was, what are you doing about the traffic?
About the traffic.
That
So
was
it's not about
of what can
so it's about the risk that can happen as a result of the traffic flow. Is that right? I just want to make sure I've got the right question before I move forward. So you're right, it's not funny because it's a really important point.
The children was the evidence.
Yeah. At this moment in time, it is absolutely clear that transportation is an issue that we will have to face, okay? I don't know at this moment in time that we've got the exact answer to your question. Okay. Come on, folks. Come on, folks. You're asking for honesty. You're asking for honesty here. You're asking for honesty. What you're going to get from me is you're going to get honesty. I will tell you what I do know and what I don't know. And I think it's important that if you want us to give some answers, okay, let's at least have it honest. You might not like what I say, but at least let's get some honesty in this situation. What you're saying is quite legitimate and is a concern. There is somebody here from the ambulance service at this moment in time, but whether at this moment in time, in the process that we're in, that they can give you the level of detail to what you're really looking for, I suspect not. And the reason why we're not in that place is because we need to make sure we capture as much feedback from yourselves about what the concerns are and issues, because it would be wrong of us, to assume that we know all the answers, because we don't. And a part of this process is to make sure we listen to what you say. But what I can give you assurance on, is this process will not carry on either from the Commissioner's perspective or a regulator or a Department of Health's perspective if that very question that you've asked hasn't got a really detailed answer at a point in time.
Never mind.
So that's the thing I want to make sure that you understand, okay? There isn't a situation here where from tonight or from the decisions that Carol has alluded to that people should think that we've got a green light to go ahead. I want to make sure you get these questions in because they are questions that are important. You'll have seen there are a few colleagues up here that were nodding their heads when you were asking those questions. I just want to get that across to people across today. It's an important question. We won't treat it lightly. We're in a process. We want to understand as much as possible. And where possible, if we know it today, tonight, we will answer it. And if not, we'll have to come back to you. I'm just hoping that will help.
Can I...
Sir, can we... Sir, please, can we take questions?
Can I just add a little bit to the conversation that we're having about ambulance journey time? So we've done a lot of work actually in terms of getting underneath the data that we have about the way that ambulance services are working at the moment. So we understand journey times. We've also modelled the impact of moving to a model like the model that we're consulting on. We've looked at what that would look like in terms of journey time if Huddersfield had the emergency centre and if Halifax had the emergency centre. And what we know is that will, moving to that model will add some time to our journey times. We know that. We know that that's the impact. Okay. What we also have the commitment on is the commitment from the ambulance service to work with us as we work through our consultation to an outcome. We've got commitment from the ambulance service to work with us to ensure that whatever the model is, we will be able to transport people safely to the care that they need. So we've done a lot of analytical work. Owen's right, but until we come out the other side and we understand the model that we want to implement, we can't finish that work. The other thing I want to say is that a lot of this isn't within the gift of the NHS to sort out.
Yeah,
but we've established a really clear dialogue with local authority colleagues. Local authority colleagues are working very hard to secure the investment that we need across this system to ensure that our road infrastructure would support a new model of hospital care, whichever site we were talking about.
Question 3. Sergeant, come over here.
Hello, I'm Barry Shearman, I'm the MP for Huddersfield. Welcome to the heart of Huddersfield. In fact, this is at the heart of Huddersfield where a hospital should be, at the heart of our community. Can I ask a question? And it's a question that all my constituents, many of them here tonight, have constantly asked from the very beginning. Why was it, for months and months and months, we were given the impression, and I as the representative was given the impression that there would be a closure of an A&E, but it would be Halifax, not Huddersfield. And I ask this question because it comes to the very nub. I was always told by all of you that the real decision would be the quality of clinical and medical care for the majority of our population. When it actually came, an emergency, when the group of you, Carol and Paul, asked to see me in an emergency situation to tell me that you'd reversed the situation and it was Huddersfield A&E that would close and Calderdale and Halifax where the centre would be. Can you answer me, was that based on clinical care, medical care, or you had looked at the finances and
Shall I pick that up? Can people hear me if I stay seated, or do you need me to stand? Okay, so Barry, you're right. 2 years ago we were talking about a different situation. We all recognise that. But what we all also recognise is we're in a different place now. So when shortly after that time, when the model was suggested around Calderdale's emergency centre, we had further conversations. The Trust got involved in discussions with Monitor, their regulator, because of the financial position. We're really clear at that stage that actually
Can we allow the panel to respond, please? Otherwise we can't have a shouting match across the room. It's just not working. We need to allow the panel to respond, please. We are, sir.
If you ask us a question, want to be able to talk, want to be able to speak back to you, and we want to be able to hear as many questions as we can, which we're not going to do if we just sort of shout all the time, and we want to be able to hear what you've got to say. So when we had to relook at the proposals, we were very clear with a lot of people at that stage that every option was back on the table, because we knew the financial position, not just locally but nationally, was worsening. We also knew that the issues that had been flagged up a couple of years ago around clinical quality and safety issues had not gone away, and that they were continuing. So the Trust were continuing to see difficulties in terms of recruiting key staff. And I'm sorry, Barry, but I do need to say we did have conversations at that time when we were very clear that everything was back on the table. So I genuinely don't recognise a position that says we were leading you to believe it was going to be the opposite way around until the 11th hour.
Okay, are there any more responses from the panel? Okay, question 4. Sir, we will be distributing numbers down there after we've completed these 10, and then we will be coming down there. But I'd like to do this gentleman first, please, number 4. I'll hold it for you, sir. Just speak into it.
My name's Reverend Mike Smith. I've been a minister here for 36 years, although I'm an arrant southerner. This is my home. I want to ask the panel, first of all, is this a genuine consultation, or is it just the great and glorious telling us plebs what they've decided anyway? Under the present proposals, we will be left with no A&E in all Kirklees, now that Dewsbury has got rid of. And if the CCG had any guts, they'd resign en masse, declare the health authority bankrupt, dodge the absolutely damnable PFI debt. It cost 64 million to build Halifax Hospital. I don't begrudge them that. I begrudge the bankers £771 million that we've got to pay back, and the government ought to stop it.
I with some of what you've said. I will specifically answer your question. The only question that I heard was, is this consultation a sham? No, it's not, and that's why we're here this evening. We're here to listen to you, and so that answers the question. We are very open to what you have to say, as we've already said, taking it all on board.
Thank you. Are there any more questions, any answers from the panel, please? No. Question 5, please. Question 5. Stand up, madam, and let me give you... I'll hold it for you. Okay, got it? No, really, I've got it.
I am Dr. Barbara Brown, retired NHS consultant and previously GP principal. Now, I don't want anyone to heckle, please, because I'll lose my train of thought. Now, I've worked in North Middlesex Hospital, A&E Hospital, as an SHO, covering the night shift from 12 at night to 12 in the morning. Calling in a consultant was a rarity. Anyone who needs specialist services, such as you are advocating for this, your argument, the ambulance staff previously advised and will get everything going. 90% of the cases that go to A&E are reasonably dealt with a junior doctor with no further consultation. This is a unit that is valued by the people of this area whom you serve. You are too tied in. You are too tied in to current national planning. It is quite possible to be more versatile. I agree with 24/7 consultant participation, and I agree historically it's inadequate. But so is the plan that you are making, currently with a fear of 30 million debt and a projected spend of 450 million, probably financed privately, with a private small unit built and charged for in Huddersfield. Your charges you pay for modernising the outpatient department which you own are ludicrous. We don't need to be posh in this world. We just need to be efficient, considerate and conscientious and committed. Now, some of the answers that you have given tonight do not meet a professional standard for the money you're being paid and being honest. To come up with a better plan. There's no reason why hospital managers should not protest about being burdened with private financing schemes, PI, which they didn't put their minds to at the time. It's time that was taken out. We could sort this problem if you are willing to look at it more flexibly. And just a little note to Steve. You're not very popular with the local GP, Steve. I have been told that you have set to one GP is going to take more than 40,000 signatures to stop this. Now, it's all right, my lad. Giving us talks about, and I'm a Huddersfield girl, giving us talks about your uncle, you being Uncle Steve. If we're going to have a problem in getting 5% to 10% of the cases to the luxury suite they need, but the rest of it can be serviced in Huddersfield if you put your minds to working out something better than what you've come up with. Thank you.
I'm going to ask Mark, the A&E consultant.
Oh, good evening, everybody, and thanks for coming. Can everybody hear me? What would you like me to do so that you can hear me? Can you hear me now? Okay. I'm not going to be able to answer all of your questions, but I will answer what I can. I'm a doctor, I'm not a hospital manager, I'm not a finance person, I'm a doctor who's trying to run as safe, as high quality emergency care service as I can. And increasingly, not because of money, because of availability, not because of money, but because of availability of good quality middle grade doctors. In the overnight period, middle grade doctors keep our department safe. They are the doctors who, if you turn up with what might be something trivial or might be life-threatening, they are the people who you need to be able to recognise that and to be starting the management of it appropriately. If I can't get a middle grade doctor to work in a department overnight, that department is not safe. And all the money in the world is not getting me those middle grade doctors to work in both departments overnight. I'm not talking about which site, I'm talking about why we need one emergency department and why we can't do it in two. Okay? Those are two different questions. Those are two different questions. Do we have to have one or can we have two, and then where is the one? And what I'm trying to say from a clinical perspective, we cannot have two safe, high-quality emergency departments. It's not possible. It's not because of the money. And that's what I'm saying. We're not managing. I go to bed at night. If I'm the consultant on call for two departments, I go to bed on some nights thinking, the doctor in charge in one department, I know who he is. He works for us on a regular basis. I know he's a good quality doctor. I know he'll identify the sick patient. In one of the other departments, there may be a locum doctor I've never met before. I've got a piece of paper that says he's a qualified doctor and a reference which says last time he worked was good. I go to bed crossing my fingers that nothing's going to go wrong overnight. That's not a service that I want. That's not a service that you want. I'm talking that things will get better.
Most of the care sector is like that nowadays.
And that's not acceptable.
And we're saying that's not acceptable. What I'm looking at here, I'm not thinking of closing an emergency department, an A&E. What I'm going to do... No, if you let me finish, I'll explain exactly what we're thinking of doing. We know that at least half of patients who come to A&E at Huddersfield or Halifax can be treated in an urgent care centre. And we plan for that facility to be there. For the other half of the patients who come to either Huddersfield or Halifax, they need to be in an establishment that's fit for purpose, that's got the staff there who can deal with anything that comes through the door and will deal with it appropriately and safely. We don't have that at the moment. I believe that you deserve better than what you've got, and I don't believe that we can deliver it as we are on two sides. This plan is for making things better for you. Are there any more comments? We have number 6 here, question 6.
Yeah.
I need to hold it, please. Yes, thank you very much. Thank you. Hello and good evening. My name is Adnan Mohammed, Dr. Mohammed, and I'm privileged to serve this area as a consultant pediatrician for almost a quarter century. And I find myself in a quite difficult situation, as I mentioned in an earlier meeting, because there are many wonderful colleagues on the panel. But I said again and again, I am totally in disagreement of their proposal. And really, the more I look to this document, what is called consultation document, the more I feel embarrassed as a health professional, worked for 39 years of my life within health services. It is full of misinformation, full of contradiction, full of everything is not good on the health professional point of view. I could mention so many examples, and really I highlighted many of these examples. For example, the one which is, Mr. Owen William mentions, for example, the transport issue. Said here in their document, there was negligible impact on the patient transport services. Do you agree that is the case? No. And there are many examples, of these contradictions. We hear something now different. We hear something now different totally from what is the document. And they mention the PFI. They mention hundreds of figures in this document, but when they come to the PFI, they never have got the courage to say how much it costs and what is the impact on the, what's being said so many times, the financial implication is the main riding force behind these proposals. However, the more serious issues, really, I could mention tens of them, but really the urgent care, which is the center and the heart of this document, what is called the urgent care in both hospitals. My friend, honestly, which is on page 23 to make it easier for you, what they are proposing is we deal with strain, with the broken bones, with infection like the throat infection. In other words, honestly, my friends and colleagues, it is almost first aid center, not an urgent care. It is embarrassing for the 21st century. And it is really embarrassing what's being proposed. If there is no other reason, to discredit this, plan or consultation or, things, for this reason is good enough to scrap the whole plan altogether. Because what's being offered on the urgent care, I privileged to work at refugees camps in many different places in the world. And they keep saying in this document, we are offering blood test and x-ray. My friend, these tests are available even in refugees camp. And the people of Huddersfield are... And honestly, my friend, that, the people of Huddersfield are not refugees and they deserve something better.
Can the panel please respond to that?
Yeah, certainly. Can you hear me? Yes? Yeah. The previous questioner actually referred to as being driven by a national policy. That's often known as the Keogh Review, and this is something that we were actually ahead of in Calderdale and Huddersfield rather than behind on. So the model for accident and emergency departments to be replaced by a network of at least as many urgent care centres supported by a small number of emergency centres is happening across the country. It is something which is known to be much safer. The whole idea of accident and emergency departments is extremely old-fashioned, as indeed is the model of a simple general hospital. The days when a single specialist could handle everything from heart attacks and strokes to serious infections are gone. They are now managed by much more specialised individuals, but they need to be together in a larger team. I'm not sure what Dr. Mohammed actually objects to, what he agrees with, but I would be interested to know, does he agree whether or not all of the services, these specialised services across our area, should be put together into one hospital? And is it just the location that he's disagreeing with? Because we are absolutely convinced that they do not work spread across two hospitals. Neither of them have the proper set. Neither of them have the proper necessary set of integrated services to provide for people in an emergency.
And why don't we close them both down? The danger is if we do not sort out our local health services, make them safe and make them sustainable into the future, then people will come in from outside and do things to them much more drastically than we're proposing to you. We are attempting in difficult circumstances to offer you the best deal that we can. And I can tell you as a local GP, like Dr. Alderton, I would not be standing in front of you proposing this if I didn't believe it was an improvement on what you've got now. One of the absolute standards that we've applied for all this is the commissioning groups would not propose anything that we did not believe was an improvement on the status quo.
Okay, question 7, please. So, now give your name where you're from.
What if you're dying in an ambulance?
Please can we allow this gentleman to raise his question?
I'm from Barnsley, Save Our NHS group. There's a group of us here today from Barnsley. And we are very concerned about the safety of patients in Barnsley, obviously. We're very concerned about the safety of patients everywhere, Huddersfield and Halifax as well. And I thought what Barry Shearman said, beggar my neighbour in Halifax, was disgraceful actually. But to come back to the issue of Barnsley, we asked a question at the Halifax meeting about the additional demand on Barnsley A&E, which is an A&E department which is already failing to meet its target response times, what the additional impact of that would be and what the additional numbers of patients and deaths in Barnsley would be. We got no answer to that question in Halifax. What I would like to ask about tonight is a related question, and it's already been raised, about the additional demand on the ambulance services as a result of these cuts in services, and let's make no bones about it, this is part of the Tories' agenda to cut the National Health Service. It's part of that overall Tory agenda, and politics can't be kept out of this, I'm afraid.
Declare your interest.
So the additional impact on the ambulance service, according to your own travel analysis, as a result of these cuts, will be that the ambulance service will have an additional 10,000 hours of journey times. My question is, have the additional resources been set aside to give to the ambulance service to cover for that, or will this result in a worsening of ambulance response times?
Okay. Before I answer, I would like to clarify, I don't think Barry Shearman said anything about beggar my neighbour at Calderdale. You didn't? No, you didn't at all. I'm not sure what you heard. I'm going to pass to Carol to answer the question about Barnsley and ambulances, etc.
Okay, thank you. You're right. We heard some comments from... Yeah, that's fine. Okay. All right. You're right. We did hear some comments from people in Halifax last week about the impact on Barnsley, and I gave a bit of an answer then, but clearly people are asking for a little bit more detail. Just to reassure you, we're in continued dialogue with our colleagues in Barnsley. So even today I was speaking to my opposite number at Barnsley CCG to get some sense about what the view was from colleagues over there about the impact of these proposals. Now, within our business case that we produced before we went out to consultation, we did set out the detail there of the findings from our travel analysis, and that indicated the increased number of journeys that we would expect to go to Barnsley, rather than Huddersfield as they might do now. So those figures are out there in the public domain, and I know that Barnsley colleagues are looking at them. What they have said to me is that they will be formally responding as part of the consultation and welcome that, either from the hospital in Barnsley or from the CCG, but we're keeping talking with them. Just to be clear, the 10,000 additional hours that were talked about, 10,000 additional journeys that were talked about, that's overall, that's not just for Barnsley. And we'll be having ongoing conversations with the ambulance service about what needs to be done to address that, because we recognise there is a need for additional investment in ambulance services to meet that demand.
Who has question 8, please? Question 8. Can you put your hand up if you have question 8? Thank you.
Thank you. My question actually has been asked by the gentleman from Barnsley, but I would further add that could the CCG please explain what representations has been from the ambulance service for this, what is going to be an apparent shortfall due to this extra 10,000 hours travelling time? Because we're constantly reading in the press nowadays that the ambulance service is stretched already. So what does the ambulance service have got to say about that?
Okay, just to say we are at Joint Health Overview and Scrutiny tomorrow, where the ambulance service discussions will carry on. We do have an ambulance person as part of these workup that we've done so far. Do you mind just raising your hand? I don't expect you to do any more than that. He's here this evening. We talk regularly with the ambulance service, and clearly we're not going to make any changes to anything without fully involving the ambulance service, because they are what the sickest people need to use, and this is all about, you know, the sickest people being cared for and being safer, and so we will use them all the way and continue to work with them.
Question 9, please. Can you put your hand up if you've got question 9? Thank you. The next lot of 10 have all been distributed over there, so please don't worry.
Yeah, I'm Joyce Wilson, I'm a resident of Huddersfield. What I'd like to ask is, why can't a town of over 250,000 people have its own proper hospital and an accident and emergency department? I'd also just like to mention, page 7 of the consultation document concerns overall points. Will Calderdale Hospital address these points? Why are too many patients having poor experiences in hospital? Why are they staying longer in hospital? Why are they being readmitted and dying? Is that the case at HRI? Are they going to be better at Calderdale?
Yeah, well, yes. I mean, our proposals are trying to address those questions that you've just asked. I mean, you've quoted the things in the consultation document, and our proposed system is going to address those very problems, because they are what we see as the current problems in our system. Sorry, I've just forgotten the first bit that you said. Oh yeah, the town site. Yeah. The problem is actually, I get 250,000 people is actually not enough people for a full hospital, as you're talking about. Okay. And Halifax also is not big enough, and several other towns. Let's take Bolton, let's take Rochdale, let's take Chorley. There's loads of them nationally around the country. As Dr. Brooks said before, this concept of a district general hospital serving 250,000 people, that's not big enough. We need hospitals serving bigger populations so we can get specialists working together, and that way, and they're looking more like 500,000 people as a minimum.
Ladies and gentlemen, can I ask you please to settle down? I'd like question 10. Number 10, thank you.
Hello, Ted Casey, long-time resident of Huddersfield. I read in the Examiner that following the closure of Rochdale A&E, that there was numerous occasions at Oldham A&E of ambulance having to wait for over an hour to be seen to at the A&E. what are the current waiting times for ambulances at Calderdale A&E, and what measures have you put in place to make sure that these are not extended when you're doubling the number of ambulances going there?
Is it on now? Yeah. I'm getting the hang of this mic. The waiting times for ambulances at Calderdale and Huddersfield aren't quite as good as we'd like them to be. They're nowhere near an hour. Answering your question about how are we going to fit 2 lots of patients into one department, part of this plan is that I get a brand new, purpose-built, state-of-the-art emergency department so that I can give you much better care at the time you need it, when you need it, with the skills that you need. I think the question was, how can you fit more patients into one department? Yep. So by having a department and a system staffed with all the skills and staff that we need to deliver a good, effective system. I'm sorry, I'm missing the question. Can you get this gentleman to ask the question again, please, so I can make sure I'm answering the question that I think he asked?
This was following a report in the Huddersfield Examiner that the number of ambulances having to wait over an hour at the hospitals at Oldham A&E drastically increased following the closure of Rochdale A&E. Now, I wanted to know what the waiting times were like at Calderdale at the minute and what measures you're putting in place to cope with a doubling of the number of people going there to make sure that you don't have long waiting times.
The current ambulance turnaround, waiting time to be assessed and seen in the emergency department at Calderdale is of the order of about 20 to 30 minutes, which is not as good as we'd like it to be. We'd like it to be less than 15 minutes. By developing a system that's more efficient and effective than it is, we will not have an increase in waiting times, and I'd expect them to improve.
Thank you very much. I'm now going to go... Ladies and gentlemen, you have to go with Q3 on spot. I need to go to the next person. Please, might go to the next person. Thank you. Right, so this is number 1 now, and this is the gentleman from downstairs.
No, it's from downstairs, this.
No, this is from downstairs, so and then once you've done these 5, we'll come to the number 1, 2, 4, 10 over there.
Good evening, ladies and gentlemen. My name is Richard Draper. I'm a resident of Huddersfield. I am an accountant by profession, and I'd like to ask the question, has the Halifax PFI liability been the prime driver in this situation? Yes. And if so, how is the new Huddersfield Hospital, in inverted commas, going to be funded? Is that going to be more PFI? Another liability for as the business case, we're all aware that resources are scarce and that there are constraints both on staffing and on financial availability, but have these proposals been subject to independent perusal?
Okay. I'm going to start that. The initial driver for this whole thing was about 2.5 years ago, and that was purely based on quality and safety of care, because myself and my GP colleagues, along with our hospital colleagues, were becoming increasingly aware that services were not of the standard that we needed, and so that was the initial driver long before finances. So that was that bit, and then I'll hand it to Owen about the PFI.
From here for the panel.
Okay, so there's 2 elements to the question. If you talk about the private finance initiative, because I know everybody sometimes that PFI, what does that mean? In terms of where we would go next, let's just say we get through this consultation process. Let's say we go to a joint overview and scrutiny process and there's decisions made, and we get to a point where then we have to work with the Department of Health and Treasury to say, how is this going to be financed? There'll be 3 possible routes. You've already indicated one, which would be potentially what is known as PFI2. Okay? Yeah, exactly. Yeah. I don't need to say much about that, do I? No. Okay. 2 other routes would be that either a combination of the Department of Health and Treasury, okay, that they give us borrowing permissions to borrow, but then they also will contribute to what would be annual payments in terms of rent. So that's another route that they could go down. And then the third route could be that they give us a capital sum, a lump sum piece of money to actually deal with the build costs. And you'll know from your accounting background, somewhere down the line, someone has to pay somewhere in that. Yeah, somebody has to pay. Now, I don't need to tell anybody in this room about the state of the nation's finances at this moment in time, do I? Okay? I don't. So, what I would say is, when we get to, or if we get to, and I use the word if, we get to that position where those decisions have to be taken, it will be probably the Department of Health and Treasury that will determine the route that we'll take. I think it'd be fair to say that if you look at the feeling in the room, that the term PFI is not a popular term, is it? Okay. The other bit I would ask, and I would get us to think about, is often in this conversation we do forget about HRI as a building, which I feel quite passionate about, actually, because the generations of our workforce that have worked in HRI, and I don't want to be in a situation where we're taking decisions and making it lightly, which is why I'm always encouraging all our workforce and whatever else to have their say, because it's as much about them, you, as it is about what we're trying to do here. But the reality is that since that building, it's been 50 years, 60 years since it was actually originated, okay? We've had a situation where there has been singularly underinvestment in the upkeep of that building. Okay? We can talk about why, we can talk about, all I know is that that's a building that contains in it things like asbestos. We had a situation 2 weeks ago, where a sewerage pipe burst. Yeah? No, you might say but for the patients that we had to displace as a result of that, I don't think it felt for them. And this is where I think we need to get to. It's not just a conversation about PFI loan or disastrous or whatever that is. It is also a conversation about what we are doing about HRI as a current building, which will require £100 million over 5 years for us to get it to a state just to last for another 10, 15 years. Now, whether we like those facts or not, those are the facts. And that hope gives you some sort of point, particularly from an accounting perspective. Yes, to the first part, somebody's going to have to pay. And we don't know how that will work out because we've got a process to go through. And on the other thing, let's not forget that HRI needs some development too. And if there's a chance for us to get a new hospital on that site or near that site, that's my vote. Thank you.
Ladies and gentlemen, I'd like to take question 2 now from downstairs. I'd like to take question 2 from downstairs.
What was that? It was all right.
My name's Chaz Ball. I've lived in Huddersfield for the last 15 years and I work in transport, so I'd like to go back to the point about journey times to Halifax. In optimum conditions, car journey time is estimated at 15 to 20 minutes. That was in the consultation. It didn't use the word in optimum conditions, but we all know that's the only way you can get there in 15 to 20 minutes. I think what I wanted to ask really is how much assessment has been done about the increasing incidence of standstills and closures on the M62. There's no one's mentioned the fact that it's not just the Elland bypass, it's the crossing of one of the busiest roads in our region. And how much have you actually looked at forecasts and evidence, if you like, of this breakdown of the traffic and the knock-on effects that occur around the rest of the area. The reason I ask this is because not everybody goes to hospital in a blue light vehicle. So not everybody can get through the traffic.
I think although not everybody goes to hospital in a blue light ambulance, that's one of the important points that we're trying to get across here, is that if somebody's very seriously ill, that's where they should be. They should not be making their own way to the nearest hospital. That decision can be partly informed by the ambulance service, either by a 999 or occasionally people ring 111 and get escalated to an ambulance. But the important point is that your treatment starts when the ambulance arrives or the paramedic arrives, and you are then in a much safer environment than in your own car. So setting off and trying to get yourself to a hospital is inherently quite dangerous. You might well go to the wrong one. When the ambulance comes, it will often spend some time at the scene, initiating treatment, stabilising a patient, and discussing that patient with local hospitals and deciding which is the correct place to go. So now, if any of us in this room are unfortunate enough to have a heart attack, we will not be taken to either Calderdale or Huddersfield. We'll be taken by the ambulance to Leeds. If we have if serious burns, we will be taken to Pinderfields. So already we have ambulances passing the nearest hospital to go to the one that's most appropriate, and that travel should take place in an ambulance.
Thank you very much. Can we move to question 3 now from downstairs? Adam, please, can we move to question 3 from downstairs?
Hello.
Sir.
Hello, I'm Chris. I'm a lifelong Huddersfield resident. We've heard a lot about ambulances, but what is the actual cost of a Yorkshire ambulance service of the increased journey times, which can be as much as 30 or 40 minutes from some parts of your area to Calderdale Royal Infirmary Hospital?
Thank you, sir. Madam?
There's clearly more work that needs to be done. So there's a process whereby we translate all the information that we've got about the impact of the model that we're consulting on the ambulance service, on the number of journeys, on the number of crews that means that they would need to commission, or people that they'd need to employ, and then there's a contractual conversation that would take place between us as commissioners and that organisation as a provider of those services. As I've said earlier in my response to the earlier question, we've got a strong dialogue with the Yorkshire Ambulance Service. We've got a really supportive relationship with the Ambulance Service, and I'm confident that when we finally make decisions about the model of care, the Ambulance Service will support us and we'll agree properly through contractual arrangements how they will work with us. But that will cost money. It will cost money. And the final business case that's consequence of consultation will need to capture those costs. I'm really sorry, sir, you haven't got a microphone.
Sir, please can we...
That's correct.
Why did you say that?
No, I've already given that answer.
Why can't you cost it?
Right, can we... If the panel has finished responding, can we go to next question?
We can get that cost and answer directly to the paper, to the question, no problem.
Right, next question, please, in question 3.
Good evening. I'm Jason McCartney, Member of Parliament for Colne Valley. The hospital is in my constituency. I live in Honley. My mum and dad live in Homebridge. We are patients of the HRI. When I returned from service in Iraq, I was very ill. I had to use the A&E. When my mum had a bad fall 2 years ago up in Homebridge on the icy pavements, she had to use A&E. I'm sorry to say that everything I've heard here this evening so far just demonstrates to me that you have already made your minds up. The aim of the consultation was to demonstrate that you had the support of the people and of doctors and of clinicians. It is so clear to me that the people and doctors and clinicians do not support these proposals. So what I want to know... What I want to know is if, or should I say when, you come to the end and realise that you don't have the support for these proposals, what is the process then for Plan B? And when you embark on Plan B, can I just give a little bit of a recommendation? Can we please have the wonderful Dr. Barbara Ann Brown over here as part of the new consultation team? So what is the Plan B? Demonstrate to me and everybody here that you are listening, and what will you do when you do decide, because I'm sure you will, that you don't have support for these proposals? Thank you.
Shared with you in the consultation document all of the options that we considered, and they go from doing very little to be made under the belief
I think it's really important to understand that, and I just want to reiterate something Owen said earlier, which is that we are determined to be really honest with you through this process. So it would have been really easy for us, it would have been really easy to put a consultation document together that contained 4 or 5 options for consultation. And actually, if you'd come to us and said, well, are 3 of these options affordable? Are you likely to get the money for them, given that they're more expensive? And would then have had to say to you, well, actually, no, it's unlikely that we're going to be given any money for something that is a more costly option. And that's why we've been really honest with you in the proposals that we've made.
Thank you. It's all question 4 now from downstairs. Question 4. Excuse me, madam, move to question 4 from downstairs, please.
I'm Roger Keeley from Home Firth. I owe my life for the last 20 years to the NHS, including to Huddersfield Royal Infirmary and St James's. Closing district hospitals or accidental emergencies is not an advance. It is a symptom of failure. Less is not more. Sorry. Yeah. Thank you. Now, Jason said quite rightly that you've obviously already made your minds up. I mean, that's been obvious all along. But what hasn't been obvious all along, but is very obvious now, is that you have persuaded no one. If you go ahead with these plans against the clear, full opposition of all the population, practically, who live here, then your decision will lack moral legitimacy. It will have no democratic mandate, and we will be justified in taking all the steps we can to resist their imposition. The junior doctors are leading the way, and I hope that people will be on the junior doctors picket line next week, 8 o'clock. And my question is to invite you to comment.
The one thing I would say is, while I accept that we haven't convinced many people in the room, I can tell you we've had plenty of consultation events so far, and the people that I've sat down and actually talked with generally speaking, have been quite supportive of the
Very arrogant.
It's not democratic.
Victoria Kennedy, local resident. A recent press release from the College of Emergency Medicine said that 20% of patients who attend A&E could just as well be seen by other clinicians. However, you've said that 50% of those attending A&E are there for urgent care, so could go to the urgent care centres. Where did you get this figure from, and why is it more than the figure cited by the College for Emergency Medicine? What if your figure is wrong and the single emergency centre for both Huddersfield and Halifax is horribly overcrowded?
Will be.
If we look at the mic on? Yeah. If we look at the description of the cases that could be seen in an urgent care centre that are in the document, the cuts, sprains, broken bones, burns, that sort of thing, we know that about 50%, just over 50% of patients who are coming to our A&E departments now fit into that group. That's where our figure of 54% comes from. So I know that 54% of the patients that come to our department are currently being seen by an emergency nurse practitioner in our department. I'm talking about the patients that come to me. We know that there's problems with GP services going forward. We talked earlier about the lack of GPs. So we're saying you don't need a GP for these sort of things. Our emergency nurse practitioners are looking after those patients now and will continue to do so in Huddersfield, just across the road from where they do it now. And that will deal with more than half the patients who are currently coming to A&E.
Question 6 from downstairs, please. The last one from downstairs. Yes, sir. Thank you.
The faces of the panel tonight tell a picture. You haven't got a clue. You don't I have an awful lot of... my name, by the way, is Ray Thompson. I live in Holmfirth, and it's easier to get to Oldham Hospital than it is to Huddersfield. And I have a lot of thankfulness for Dr. Mark Davis, who talked to my wife when she was critically ill. Thank you, Doctor. At a public meeting about 10 years ago, held by the Huddersfield NHS Foundation Trust, regarding the removal of special care and maternity provision for Huddersfield Royal Infirmary, I asked a question which a simple answer was yes or no. The question: have you already made your mind up that maternity provision will be moved away from HRI? Answer: deafening silence. History seems to be repeating itself. Not so long ago, Kirklees had to find a new site for the increased demand for burials. The chosen site is already filling up. Right care, right time, right place. Well, I suppose that the people of Huddersfield should be grateful. You might not be able to be born here, but at least you can be buried here. It's been asked before, you haven't got it, but I'll ask it again. What is Plan B? What is Plan B?
Okay. We have put these proposals out to you and we are listening, okay? If we need to modify things, if we need to modify the current proposals, then that will be Plan B. But at the moment, this is our Plan A that we're presenting to you, and we'll listen to what you have to say.
Right, question 1 now, and we're back in this room. So the 10 people from back in this room, please, sir.
Hello, good evening, everybody. My name is Fernando Lani, born and bred Yorkshireman from Huddersfield, born in Huddersfield. I'm going to ask Owen just to say the word honesty again, because so far he's used it twice, but he doesn't understand the meaning of it. Also, Dr. Steve, you are a very good, qualified doctor. You are no businessman. And all you people back there, some of you in the profession of doing what you are doing within your pamphlet have been doing this for 13 years or more. You should sit there with your heads held in shame. Because as Pride Yorkshire people and Huddersfield people, some of you with Welsh or Scottish or whatever other accents you have, do not have the pride and passion of the people in this room. Okay? On your admission, our hospitals are in such a bad state at the moment. Because of you. Because of you. Right? You should not be entrusted with our national hospital in Huddersfield. I'm not the most educated person, and I'm telling you, and the people of Huddersfield are not happy with your decisions or your prospects for the hospital of Huddersfield. One simple, truthful question, and I would like all of you to answer, if possible, not just the nodding dog syndrome. The question is, why should we trust you? And if we can't trust you, clear off.
Okay. You going first, Owen.
Wilson, from one proud Yorkshireman to another, the reason why I think you can trust not just me and the people here, but also a number of the clinicians, doctors and nurses that I know are in this room, is because we care about the services in the same way that you do. And the reason why we're here and we're willing to take whatever you're willing to give us is because the one thing we don't lack is a lack of conviction. Because we believe in what we're doing and we believe that we're doing it for the safety of our patients. Okay? And let's just get straight. So let's ask the question. Is it just this so-called Calderdale and Huddersfield NHS Trust, or the social care areas that are in this area, or the general practice areas that are in this area that are just unique to the rest of the United Kingdom? Answer, absolutely not. We're in a situation where this year we've had to deliver, and I'll say this, deliver a £20 million deficit on an expenditure of £352 million. That's 20 million. That's 20 million as a part of 2.8 billion nationally, where trusts like ours, economies like ours, are in debt today. So there is something happening, not just here in our system, but something happening nationally in this country. And what you've got here with this group of people, okay, and we haven't always been friends, let's be honest, but what you've got with this group of people here are people who are fighting for services and care in this service. So you ask for a response, that's the one you get from me.
Next one, then.
Okay.
My name's Janet Yound. I currently chair the Royal College of Nursing Emergency Care Association. They elected me to be their chair and spokesperson. I have been an A&E nurse for over 25 years. I'm a children's nurse. I know that what we have got at Huddersfield and Halifax is not the best care in emergency care for children. What I want is a dedicated children's department. The department's not big enough. I can't recruit children's nurses because currently, I was studying Huddersfield A&E department on Wednesday afternoon. There was one child there. I can't recruit a whole team of children's nurses to look after one child. If we pull them in one hospital, let me speak, if we pull them in one hospital, we can have children's nurses and children's doctors in the emergency department. Now for me, I'm a clinician, I don't mind where that hospital is. But financially, it is impossible at the minute to look at doing that at Huddersfield because Huddersfield needs so much work doing on it. So I'm being honest with you, I want one emergency department.
Ladies and gentlemen, before the next person responds, please, the panel is listening to your questions and they are answering them. You must allow them to speak. You must allow them to speak without heckling them. Okay. Yes. Sorry.
Hello?
Leave it on.
I know that people trust me because 70,000 come every year to my department to see me. They come to see the service that I'm delivering. What I'm saying is the service I'm trying to deliver,
ladies and gentlemen, please.
The service I'm trying to deliver is not as good as it could be. That's all I want to do. I want to give the best service that I can to the people of Huddersfield and Halifax. No, I wasn't elected, but 140,000 across both towns vote with their feet every year, and I don't think they're getting as good a service as they could get.
Okay then. I am the elected clinical leader of over... I'm the elected clinical leader of over 100 GPs in Calderdale, and I know that they widely support these proposed changes. But also, importantly, I am privileged to be the GP, the senior GP in a practice looking after 4,000 patients. That is not something I take lightly. I experienced with them what goes well and what goes less well for them within the health service. We GPs have got a unique perspective on what happens to patients because of the large number of people that we see over many years and the good things and the less good things that happen to them. And that experience is being brought to bear in this consultation, in these proposals. I hope I can be trusted because I represent those patients as well, and I would not put anything forward to you that I was not confident was in their best interest.
Is it my turn?
Go on. We may as well keep going. Go on.
So
Yes.
I'm not going to try and persuade you to trust me. But I'll tell you who I am. I'm Matt Walsh. I'm a husband. I'm a dad. Can you just hear me out? I live in Calderdale. I've lived in Calderdale for the last 16 years, and I'm really proud to live in Calderdale, and I'm really proud to have a job where I can serve the people of Calderdale. My background is in general practice. I'm a doctor. I've not been in clinical practice for the last 3 years, but it's my route as a doctor that guides me in the conversations that we're having about change. I can't sit and watch the system that I'm responsible for fail to meet the needs of the population that I'm responsible for. No. I've got a broader view than that. Well, you can shake your heads, but I'm telling you who I am. Okay, I've worked across West Yorkshire. I've worked in Bradford. I've worked in Leeds, and I've cared deeply about all the places that I've worked in. I care deeply about this place. I don't care whether we're talking about Calderdale or Huddersfield. I just want to try and be part of a piece of work that will deliver something that I've got more confidence in than I've got confidence in our existing system. That's why I'm here. That's why I'm doing the work that I'm doing, and I'm really proud of the people that I'm working with, trying to get something better for our system and for our patients.
Shall I go? Okay, this microphone, is it on? Yeah. Okay. Let me just say a little bit then about my contribution on this. As you've rightly pointed out, I'm obviously not from Yorkshire. I've lived in West Yorkshire for the last 22 years and I've worked in Huddersfield for 16. Now, what I can say is, when you're in the kind of job that I'm doing in the NHS, you get reorganised quite a lot and you get an opportunity to apply for jobs in a number of places. In the last 16 years, I have always chosen to try and work in Huddersfield, and that's why I've stayed. And the reason I stayed here is because I believe that the practices that I work with really closely, that the staff that we've got working within the NHS are absolutely committed to doing the right thing. And I have chosen to stay here because I want to be part of that. From a personal point of view, me and my family have used services in both hospitals over the last few years. Like a number of you in this room, some of that time has been the most difficult times of my life. And I want to make sure that actually the way we design services going forward stays that way, so that we can continue to deliver top-class services to the population, not just of Huddersfield, but of Calderdale, because all of us use services in both those towns now.
Thank you. Apart from being a very unpopular GP, thank you for highlighting that fact, but I am the chair of the organisation, and I think the majority of the GPs in Huddersfield do support these proposals because they help me design them. Okay, I'll answer the question. Can you trust me? You might not like to hear that I was actually born in Merseyside, and I don't know whether any comments about Scousers, but anyway, that's me. I came over to Leeds University at 18 and graduated and stayed over here ever since. So, because certainly I thought West Yorkshire definitely the place for me, and I started working in Skelmanthorpe in 2003, so I've actually been in Huddersfield for 13 years. I work about 10 at the moment. Okay, David, you didn't quite get to have your say.
Sorry, can everybody hear me? Yeah, so I'm David Burton, and I'm the Trust Medical Director at the moment. I'm a microbiologist by training, so I deal with infectious diseases. And I've worked at Huddersfield Royal primarily for, since about year 2000 actually. I did my undergraduate training in Leeds as well, so I'm committed to West Yorkshire. One of my responsibilities as the medical director is to make sure that the quality of care we give is the best it can be, and I work with my medical colleagues and nursing colleagues to try and deliver that for the population that we serve. And we have some real challenges that we're facing at the moment. Particularly in some of our medical specialities where we have a lot of vacancies. So, let me give you an example. Some of our complex... Okay. So, with my colleagues, we're trying to do...
Can we get some more questions?
Can we just have one more? I just want one more answer from David Hughes, please.
Yeah. Hi, my name's David Hughes. I'm a GP on Greater Huddersfield CCG. I'm their urgent care lead, so you can throw rotten apples at me because part of this has been my design. I have been a GP in the Home Valley for 29 years. I live in the Home Valley. Two of my 4 children were born locally. You will not find a more passionate advocate for the NHS than me. Both my parents were at medical school when the NHS was formed and have worked in the NHS for all their working lives. I've worked in the NHS for all my working life, and I wish to be part of producing something that is better than we have now. And actually, if you're asking how can you trust us, it's because I work in this system. Like Steve, I see people every day of the week when I'm in surgery, and I know that actually we can do better than we're doing now, and I know also that if we don't do something, things are going to get worse.
Thank you, David. Thank you.
You telling these people you're 100%, mate? Is this guy telling you you're 100% in your surgery?
So we are... Can I go to number 2, please? Yeah.
Better than a football match, isn't it? Just some points that sort of come up through some of the answers we've received from yourself tonight, and it's not part of my main points that I came with, but I think what you folk have to accept is that we as ordinary Joes, citizens, whatever you want to call us, a lot of the time with our health service we have to put up with stuff that's just done. We don't have a say in many things. Before you lot were sat there, somebody made a decision to set routes, straw tall. And yet we're constantly told, and it's only a week or 2 back now, there was a big emphasis on mental health and the lack of function for them. Now, a lot of what we've talked about tonight has to do with, physical issues, injuries, illness,
babies, the whole shooting match. But I think, you know, generally, whilst I'm blessed with the fact that I hope I'm not never going to get into a mental health situation, but it's always a possibility. The figures are standard. You health professionals should know that. How many men, how many women are going to have a mental health issue in their life? And we've aggregated it around here. We've put up with that. But let's just consider this situation about yourselves. Knowing the finances were stretched, for whatever reason, you know, reduction in government stuff and everything. Please. A simple question. You don't have to answer it because I think we know the answer. If you knew a year or two back that there was issues about finance and there was issues about that poor building up there falling down in Acre Street, why did you tart up the reception area? Why is it across the cafe thing and a shop and all that? Chucking money at it. And that brand new sort of reception place. You know, you did all that. The silvery sign out the front. That's not what I call patient care. We know where the hospital is. You don't have to put a fancy sign there. That's sort of window dressing. And that's what puts us ordinary Joes off. You know, we get tired of it. You tell us there's no money, and then we see that sort of... You know, my question will get it, don't worry. A lot of you people have seen the rising debts. You admit to that. We've had it since 2010, haven't we, specifically, if we think about it. So, you don't negotiate things like paying extortionate agency fees. We hear complaints about it. What are you guys doing about it? Are you getting down to the nitty-gritty of sorting that out? That's something that would help your situation. If once there was such a situation where, I mean, I know of somebody personally who was an agent for one of those organisations. 10,000 a week for that one guy is not unusual. 10,000 a week. Out of order. They're the kind of things that want addressing. Right. Sorry about this one. Those employed to manage our NHS need to remember that we are the paymasters. Not merely customers, clients, or service recipients, or whatever it's called. Oh, that's it. And the last point. No, it didn't quite. Experts, maybe some of you guys, maybe somebody else, I don't know to blame, they carried through that PFI contract. They processed it. They ticked it off. They agreed to it. Did they look at the small print? No. Did they look at the debt that they were going to get our money into?
Where are they?
Yeah, are they still around? So there's an issue there. And let's be honest about it, and I don't care what you say tonight, Steve, but in the thing you put that was put in the Examiner, you said in no uncertain terms that the PFI was the sole reason for all this. And on another note, this isn't aimed at you, because we have had 2 local MPs in here. I know, a few other people might know, that some of the PFI contracts have been, shall we say, addressed by Mr. Hunt's department. I would ask those MPs and anybody else who can have a word elsewhere, that maybe it's coming up to a few things that aren't so good for the government, you know, like Europe and other things. I'd like to think that some words are put in to get that burden off our back. Not just your back, our back.
I actually, yes, absolutely, and I hope our MP colleague, oh, they've gone, never mind. We have said this to them, and they've said, well, the first thing when we mentioned, when we talked to Jason McCartney just at sort of Christmas time before this all came out, is his first reaction was, well, we need to go and do something about that PFI then, don't we? I'll go and lobby higher up, and we're like, fine, get on with it, brilliant, you know. The more noise they can make upstairs, the better, and you know, anybody that can write a letter to their MP and say that, then great.
The
PFI, we didn't negotiate that, you're right. I might let Owen deal with that. And there was one other thing. It'll come to me. Owen, can you answer about tarting up HRI and things?
Excuse me. Well, the one thing it does show is that we weren't of a mind to be getting rid of HRI, if you know what I mean. It does mean at that point in time, we were very, very clear. But as I said to you, there has been significant changes, not just in our local circumstances, but there has been changes in national circumstances that we cannot deny. And really what we've got to do now is, it's absolutely right. Everybody's views in here are legitimate, okay? You're not going to hear me decrying any view that's put here, because I respect the people that are giving those views and I respect every word that you've said. The PFI, there's no point me looking back about who did it, because quite frankly, there's none of them around. So all I can do, yeah, you're right, maybe we are going through a full circle, I don't know. But what I do know is, we're here trying to help and assist all of us getting to a place which is about the future and making it sustainable for us all. Now, I absolutely accept that lots of people in this room will not agree with what's on the table at this moment in time. We've been asked the question about, is this a done deal? I don't think it's within this group of people that I know to be a done deal. So part of also what we're saying is, as well as saying, no, this is what we don't want, if we can also give some thought to what we do want, and if yes, somebody said, what's plan B? Well, one thing that is plan B is that we, and the good doctors and nurses and therapists and cleaners that I work with, will do our damned hardest to keep the services afloat. We will do. What I will say to you, it is very, very difficult. And each year, I'm in my 4th year now at the Trust, and each year I've seen it get worse and harder for those clinicians. When you're there at midnight and you've got 72 people presenting in your A&E, that is hard, okay? And these proposals are about us trying to address a brighter future. So every point you've said, there's not one where I'm saying, well, I think you've been unreasonable there. I understand the points that have been made. What we're just trying to do is make sure that you understand what's behind our proposal. And I'm just thanking you at least for giving us that opportunity.
Can we allow this gentleman from the back, please, to ask his question?
Initially, I wanted to say about the proposals that have been done, but it's quite obvious, and the Reverend referred to it and a few others as well, that it's not really a consultation process. You may say it is, but it isn't really. Because 3 or 4 times you've already slipped up where you've said, my design, and you've referred to it in the affirmative rather than, well, we think this is what is going to happen, but we're not quite sure. Those were my questions. But my good lady, and you may have done this already, I don't really know, but she just says, well, there's a trouble with Calderdale, there's trouble with Huddersfield, why don't you build it between? If you say you want a design that is fit for purpose, then why don't you build it somewhere around Amery Top? There's plenty of land there. Plenty of land there, and it's about finances, William. And I do believe you are a genuine guy. You sound genuine to me, and I do believe what you say. But if it's finance, which it obviously is, and we know where the problem lies, it's with the government, but we're not going to go political, but you can't really not do. But if it's finance, and it really is, you've got 2 hospitals there that are tailor-made for development. Why don't you build a purpose-built hospital with everything that you've put forward, everything that you want, to provide for us a better service, a better quality? Why don't you sell off your existing assets, get a loan, build a purpose-built hospital in the first place, get the staff in, get the doctors in, build it exactly as you want, and then sell off your land, because that will finance what you need. It will.
Okay, I've got this big cut, I think. Okay, I think, because there are some of our clinical colleagues here from CHFT, I think if you said to them, we could get to a single site where we could provide care, would they accept that? Would they like that? I think the answer would be yes. I'm looking at a couple of them just to see whether I'm smoking this. It's true. They would like to get to that place. And one of the things... Sorry?
Of course they do. They've been told to say that.
Well, I think a member of the audience has just talked about if in the ideal world, the place we could get to would be a single facility, let's say Ainley Top, okay, and it did the planned care and unplanned care that's been talked about here, that's the place that we kind of like to get to be. What I would say to you is, and I come back to this, we've had thoughts around that, okay, and when we've looked at it, the finances don't work out. However, what's really important is, if there is enough critical mass, and this is why this having your say is really important, and this is why in our trust, there's no 3-line whip. There's been suggestions that there's 3-line whips, but there isn't, because I'm saying to our workforce, have your say. And if part of the answer is that we need to go back and say it's about single site, then we need to be also able to describe what do we do with the PFI, okay, and where do we locate it. And if that land is available and we could do a single site, will the government let us sell that and use it to invest in a new site? These are all questions. But the important thing is, if that's what people passionately believe about, use this consultation process to get that view put in. That's all I've got.
My name's Julie Thwaites. I've been in nursing for 30-something years. I started as an army nurse. Then I went into A&E nursing, so I beat you on the panel. Then I actually went into palliative care nursing, which I've been doing for a long time, but now I'm disabled, so I can no longer do it. Now, I actually know that both A&E department nurses are already not hitting their targets for sorting patients out. What I want to ask the panel is, how are you going to sort that out if you move it all to one A&E? And you have already said you can't recruit enough staff. How are you going to sort it?
Can you hear me? Thank you for that question. Yeah, I agree, it's a massive national problem, is recruiting emergency nurses. And as an ex-emergency nurse, you will know that you cannot just draft in any nurse into an emergency department to do that initial assessment. Likewise, you cannot draft in any nurse to look after children. And what we have to do nationally is make the specialism attractive again. We need to invest in development so that people realise they've got a career in emergency nursing and they're not just coming to work and day in, day out, slogging over patients who are in the department too long, going home disappointed because they've not given them the care that they want to give. What we need to do, and I firmly believe, if we've got urgent care centres, we can grow that nurse practitioner development. We've already seen it in some GP practices. I'm sure you've all seen nurse practitioners. We already have them in the emergency departments. We need to grow that next generation, and we need to have those specialist nurses with dedicated career development and professional development in one centre. And I agree with you. Nationally, nobody in this country in a type 1 emergency department is hitting those targets, and it's about time we address the whole system to look at that.
My name's Ray Smith and I'm a resident of Huddersfield. I'm here to play. Why can't the CCG do what Transport for London did and refuse to pay the PFI contract? There's one question. I also asked a question at the public consultation that I went to and asked the chairman, who do you pay the money to? It pays 22 million a year and you don't know where it pays it to. How are we supposed to have faith in people who make these important decisions on our lives, who have such a long association with complete and utter fantasy? I want to know, can we propose a vote of no confidence in the CCG and its decision-making capabilities?
Can I just comment on the PFI payments and the refusal to pay? It's not the CCG who pays the PFI. That's a contract between the trust and the. Is it Catalyst? If I got that right, one? Yeah. Yeah. But I mean, it's an interesting point. That it's a bit like saying, you know, can't. Well, first of all, I think we've explained through the various documents in the meetings. A lot of work's been done to actually see if there is any way out of that contract, or if it could be changed to make it more affordable. And that, I think I've heard it described previously as impenetrable, so that has gone nowhere, despite having some, you know, some real fine minds looking at it. Can I just, do you mind, can I just finish? Can I just finish? It is a little bit there, having done all we can, and the trust having done all we can to explore if there's any route out. It's a little bit like saying then, why do we just stop paying your mortgage? You know, if this system stops paying its debt, that's not the right way to go either. That's just going to land us in a whole load of other bother when we end up in court because, you know, we're not meeting our contracts. So it's not quite as simple as just don't pay.
If you end up in court, we'll get a new team, won't we?
Just the other thing to say about as the CCG, I mean, NHS England are technically in charge of the CCGs, and if they are not happy with the way our CCGs are performing, then they can take the appropriate action.
It's up to the CCGs to do it.
I'm Brian Dobbins. I'm one of the consultant surgeons from the Trust. And first of all, can I just say that I know the panel. I know we've been a bit hard on them, but I don't doubt their integrity as to what they think is doing the right things. And I think we're giving them a bit of a bad time for this. However, as a clinician, I'm not going to ask a clinical question. I work at Huddersfield and Halifax, both sites, and I know in the proposal there is a planned proposal for a new site. The question I have is, where is the new build going to be at Calderdale? Are you going to build on top of the old one, on top of the one that's there? Are you going to build it? I'm not aware of any architect's drawing or true plans, and with this in mind, you've put a lot of costings together as regards to how much it's going to cost, and yet there are no plans out there. There is a huge cost of, is it £400 million? There's supposed to be a saving of about 31 million. Now, anyone who's had work done on their own house would have told a 10% contingency plan, and you usually spend 15 or 20%. Is there not a fear that when you come to prices of property, by getting the plans drawn up and so on and so forth, that actually your plan will be more expensive than an alternative? And when do we get to know? And if that is the case, do we scrap plan A?
Living proof that we don't have any free live whips in our trust. You know, people get to say it as they are. So it's interesting, isn't it? Because if we had fancy damn diagrams up here right now, the very thing that people have been criticising us for about done deals and all that sort of stuff would be what would be labelled as right now. So a lot of the stuff that we've done so far has been done by independent architects, people who are familiar with building sites and facilities and whatever else. So the site that is currently, and where it would currently be proposed potentially to build at Calderdale Royal would be effectively on the maternity car park. It wouldn't be on the existing, building, okay? So that's where that would be, and it's already pretty well documented in terms of building both the urgent care centre and the planned, it's all right. You know, in terms of, you know, the planned care facility with the urgent care facility there, the plan would be to build that adjacent on the same side of where the Acre Mill site is at this point in time. We are probably not going to get to that level of detail until we've heard. And this is the point. There is irony in this, isn't there? Part of what we're trying to do is to make sure, you know, are there other thoughts, ideas? This is what the consultation process is trying to do. There might be some real gold dust that comes out of this 3-month consultation that adjusts the thinking. And therefore, you are going to be in a position whereby then you might have to rethink, remodel. So there is that. And in the latter point of the question, it's absolutely right in terms of whatever financial figure that we put onto it, there is a reality about overspends, all sorts of things. We know equipment costs, build costs can change. The one thing I do know is that the Department of Health and Treasury in this environment are not going to let any plan get passed unless it's absolutely robust and as foolproof as it can be at that point in time. So I just want to give you that assurance, and obviously, you know, we can discuss more if you want.
So my name is Philippa and I live in Huddersfield. It was recently in the Examiner about the beds in the waiting long hours, so what are you going to do about this? And if you close HRI down, what's going to happen to it? So we need our answers, what's going to happen to it?
Seeing these, I'll say that, seeing corridors full of trolleys and that in the Examiner is actually kind of the reason why we need to change it, really, because you're right, it's not working at the moment. And that's why, with Care Close to Home, with redesigning the whole urgent care system and making it work in a different way, we can avoid having those trolleys in corridors, ambulances waiting over the urgent care. We have to make it better, and that's what we're intending to do.
I was going to say exactly the same as Steve. That's a symptom of a failing system, and what we're trying to do is make it better so that those sort of things are a thing of the past. At the moment, we can't think of an alternative solution to this problem. I've been trying to fix this problem for the last 6 years since I've been in this post, and every time it comes back to, again and again, the only way we can make the urgent care and emergency care system work in our area is by having one emergency department. That's where we're at the moment.
Like I
mentioned earlier, where it is, I don't care where it is. The important thing from a clinical perspective, to give the quality of care that these people of Huddersfield and Halifax need, it has to be one emergency centre.
Sorry, can I just very briefly add that if it's going to cost a load more money to have it in one site than another, that money comes from somewhere, and that money comes out of the services that the two CCGs have got to spend on the population of the two towns. So from my point of view, as a Huddersfield resident, having worked here for 29 years, I would prefer it went where we get the best value for money than actually satisfying one town or another's population.
Sorry, I'm Jules from Home Firth, and sorry, I'm going to try and keep as calm as I can because I am really angry and I'm really upset about this, because this is not your hospital, this is not your NHS, it's ours, and I owe my daughter's life to this NHS and I love it, and I will not see this. You have, between Jeremy Hunt, between PFI and you lot, frankly, it's a mess. And we're being asked to pay for that mess. And that's not on. It's really not on. And what makes me so angry as well is this isn't just about the A&E. This isn't just about the A&E. Expecting us to go to Halifax for these services is really not on. It is one thing if you've got a car. But a lot of people haven't got a car. A lot of people haven't got a car. When did you last get on a bus from Homefirth to Halifax? When did you last do that? I bet you never have. And that's what you're asking people in Homefirth to do. people who are disabled, elderly people, and young people, and just poor people who can't afford a car to get over there. It's shameful. You've also got a legal duty. You've got a legal duty, because unfortunately I know about the law here, under the public sector equality duty, you should have put in that expensive consultation brochure of yours and a quality impact assessment explaining how these changes are going to impact on those people. And you haven't done it. Because you don't care enough. You don't care enough.
Okay, I'll work my way through. There are a few points there, and you might have to remind me if I don't address one of the points. Have I ever got on a bus from Holmfirth to Halifax? No. I have used the bus to get from my part of Halifax into the middle of town. It's absolutely clear in our consultation document that we've clocked the issue of travel and transport. It's absolutely clear that it's causing you a huge amount of concern. That's been heard. What we've said in our consultation document and in questions that have been raised subsequently is that we'll create a group, a forum where we can explore some of those issues more widely. We can start to engage with voluntary and third sector and other organisations who can help with transport. We'll make sure that we've got appropriate car parking. We'll make sure that we've got appropriate car parking built into our plans. Once we're outside out the other side of the consultation, we're clear about what we're doing. I've talked earlier about the ambulance service and the work that we're doing there. So we've clocked the issue of transport, we understand, and we're keen to maintain a dialogue with people who are interested so that we can work together and deliver something better. So the equality impact assessment isn't in the consultation document, but it is in the pre-consultation business case. There's a detailed quality impact assessment that is available on the Right Care, Right Time, Right Place website.
Dr. Steve Ollerton has been quoted by the BBC News site today as saying that it was purely a financial decision that Calderdale had to be the emergency centre because it's a PFI, and previously there is no plan B. Aside from the fact that this offers no persuasive clinical benefits to support the proposed closure of HRI, how are we, the people that you are meant to represent, meant to reconcile Dr. Ollerton's statements with his previous inconsistent assurance that this is not a done deal, and crucially, have any faith in the fact that this is meant to be a public consultation process as opposed to an arena for you to impose your views on the public?
Okay, yes. I was quoted as that, saying that the clinical model, as we've said many times, could have worked either way round, okay? And I have said, and it is true, that finance has been the single driver that made Calderdale the emergency site, and in my presentation, the criteria, it did mention that fact, that actually it would have worked the other way round perfectly well, apart from finance, and we need to get value for money for taxpayers' money. So that's what I quoted. I've said there isn't a plan B. Plan B, from my point of view, I mean, I'm only a doctor that's designed a clinical model here that I want to work and I want to get it through. I'm sorry that you feel if I'm imposing that on you. It's my best effort, okay? Me and my colleagues, my best effort. Clearly, we are hearing lots of things that we're going to feed into that, and you know, I've said it tonight, we may end up at a different plan B, but I am sticking with plan A because that's what I've designed with my colleagues, and I think, you know, it's got a good chance. Yes, we may need to tweak it, but it's got a good chance of being better for the whole population.
Next question, please.
Hello, Andrew Cooper, local resident. This is a Plan B question. At the moment, with Plan A, that's the only thing that's on the table. And my question is, have you actually assessed how much it would cost to provide a A&E and urgent care services and all the things that we require at both Huddersfield and Halifax? So we are able to go to government and actually lobby them for the service that we all deserve in our areas, because that's the way that we need to approach it. We need to have a plan B. We need to have people to put that together. And at the moment, that doesn't exist. You're not going to get anywhere with plan A. Plan A is not going to happen. I think you can see from, you can see from what everybody's saying here and for all the lobbying that's going to happen, you ain't going to get this. So you need to start now on plan B. We need to know how much that's going to cost and then take that from there.
First of all, just to remind ourselves what we've said several times already this evening, we started this process because of clinical issues, not financial issues. That's what took us there. Can you just let me finish, and hopefully it will make sense. We started the process because of clinical issues. When it came down to making an assessment about which was the preferred site for each of those services, that's where finance came in. Finance was not the reason we started this process. And I think you said, where's your plan B, where's your costing on the other options? So you've heard from colleagues tonight that they said, I think we started off with something like 11 that came down to a short list of 5. There are costings behind them. But what I've already said previously is we know that if we're going through the process that Owen has described to talk to the Department of Health about securing funding for this, we stand less of a chance of getting funding for something that is a more costly option. So that's why we're not putting them forward. However, again, just to emphasise what people have said, if there is anyone in this room, and I know that the MPs have previously suggested they might have some better ideas, then let's hear that as part of the consultation process. We are open to hearing that. So, there's place within the consultation response survey where if you've got those thoughts, let us have them. But please be assured that detailed costing has been done on other options, which is why we've landed with the proposal that we have.
And just to add to that, again, going through what Carol says, when we originally set off, the problem is trying to do everything on 2 sites. And your proposal we just put there is saying carry on trying to do everything on 2 sites. That is the fundamental problem with our current health system at the moment, and that's why we need to put a lot of the specialties together so that we can actually help save lives in a better system. We can't do it twice in 2 hospitals because it's not working.
Well, why don't you travel backwards and forwards instead of letting us
do? Good evening, everyone. My name is Oren Sah. I'm one of the consultant surgeons who works at Huddersfield in Halifax. Appreciate the difficulties you have as a commissioning group to make these decisions, but I should go on record as saying I disagree with the plans, and I do believe the emergency care centre should be at Huddersfield. And there are 2 very practical reasons why I think that's the case, and I don't think these have been looked at in the consultation document. The majority of patients we look after within this organisation are from a Huddersfield postcode. So by changing these plans, by making the acute care place in a different hospital, you'll be making that care for the majority of our patients harder to access. The second reason is that your consultation document simply does not provide a hospital that's big enough for our current inpatient base. I was supposed to use this time for a question, which I will use to illustrate this point. It's a very specific question, and like a very specific answer. The consultation document allows for 56 inpatient beds for general surgery and urology. That's the plan. As of today, at this time, We have 99 general surgery patients and 22 urology patients, 121 patients currently as inpatients for emergency surgery or major surgery, all of which would be at your proposed Calderdale site. Were this move to happen tomorrow, where are we going to put those 70 patients?
Okay, so in terms of how do we cope with fewer beds and increasing numbers of patients, I mean, clearly the consultation is not just about reorganising hospital services, it's also about making sure that only patients who need to be in hospital beds are there. And we know that we have some variations. So we have work to do about making sure that when patients are fitted up to leave hospital, they can do so in a timely manner. And that's still a challenge for us. Not just across surgery, but across all of our specialities. So it is about how do we make sure that only patients who need to be in an acute hospital bed are in an acute hospital bed. It will require us to work differently across primary care and the acute sector.
Can I just check if we could just give the mic back to a colleague as well? I'm sorry. Can I just check as well? When you're talking about services being in Huddersfield, can you just clarify what you would mean in terms of what services would be offered in Calderdale, or are you talking about the whole kit and caboodle? Could you just clarify that, please?
Don't sound stupid, don't quite question his integrity.
He's one of the best people that I work with. I would never question his integrity. He's a top quality guy.
Just to be clear, there are 56 beds on the proposed document for major surgery and emergency surgery. We have, at the moment, 121 patients in Huddersfield who fit those criteria. Where are those 70 patients going to go?
Yeah, so what's saying, I just want to just check, is what you're saying that actually you would see all the services that we provide that would help service those people in the future be on a single site in Huddersfield? I'm just trying to understand that point. Because it will just help. Or are you suggesting that we carry on as we are? I just want to understand, are you suggesting we carry on as we are? Sorry, help me answer the question.
Just to be... So, this is about the consultation document produced, which has 56 beds. It is not enough to provide the care for the good people of Huddersfield.
So, I think that is exactly the type of question that needs to be tested in this process, because, and it is linked to the point that David has talked about, the lens that we're looking at services right now are the lens that we know. So it's how we provide services today. Part of what these proposals are about providing services not just in hospital, but out of hospital differently as well. And it goes back to the question that I think was the very first question that talked about general practice, if I remember right, and about the need, you know, the really good question that you asked, which was about actually we have to think about re-engineering and doing things differently to what we've done in the past. And my point to you is to say, part of these proposals, and it also goes to our clinical colleagues as well, is about envisaging providing services in a different way to meet the needs of our patient. So it's a good challenge around the 56 beds, and based on what happens today through the lens of how we provide services today, but part of what we need to do and what we would want to work with yourself on further is actually getting to a point where we remodel the care. Because I think what you would accept, unless you're saying otherwise, and you know you may have a view, you know we can improve. Because some of the work that you have been doing and the changes that you have made and led with the team around laparoscopy and stuff like that is some of the best stuff that is seen in this United Kingdom. But it's because you changed what you did. Is that not right?
Yeah, let go. Not that, me. Right. First of all, I first stood out down this side here And when you look across the table, you can see the noses like that. For one thing, because there's so many stories. There's a gentleman saying here, it isn't about money. Is he lying? He never denied it. There's a gentleman doctor down here who said he went home knowing he hadn't given 100% to his patients. Now, can you believe that? I'm glad you ain't in my surgery, obviously. But my question is, you were telling us early on that it's going to cost £100,000 to redo the hospital. Fine. Can I ask, you're all married? You're all married gents? You're not married? You've got a wife? I'm going to do in a minute. And you're all married, as I am, as majority of the people, and I've got a wife that'll say to me, that back bedroom wants decorated. Then she'll come, the kitchen wants decorated. She don't wait until it's all tearing off the walls before she has me does it. We keep up with the job. Why don't you? So I can spend your 100 grand. Thank you.
Yeah, we agree with that. It's 100 million actually.
But you're letting us do it for
the thing is, no matter what happens, you know, however we end up doing this, anything that we decide to put in is going to be, you know, 3-5 years down the line. You can't just think, oh right, we're going to change stuff, let's stop doing everything today. You have to keep going, and that's why we have had to put in the silver sign and the cost of coffee. I mean, you know, you've got to keep, we have been keeping up with things, but it has got, you know, you can't change the asbestos. You can't make the corridors wider by spending money on it. The building's not fit for purpose.
What you do, you work different, you work smarter, and you work better.
That's what we're trying to do.
No, you're not.
Just give us plan B and I'm done.
Ladies and gentlemen, I think we're going to have to bring the meeting to an end now. So thank you very much. What I would like to say, I'm afraid we've gone half an hour early, half an hour over, sorry, and we have to finish now.
That is important. Life and death. This is important. Life and death.
Ladies and gentlemen, before you go, what I'd like to ask you to do is the forms that you were provided with at the start, could you please hand those in on your way out, particularly the question form and the equality form and your feedback form on this evening. I'd like to thank you all very much for coming along. It's been a long debate and a long discussion. We have appreciated you coming along. We still want to continue to hear from you. Okay. Yeah, so.
Come on! Stand up! Stand up! Stand up!
Hand it in at the front. Hand them in at the front.